Bismillahirrahmanirrahim. Assalamu alaikum everyone. My name is Dr. Uziar Ahmed. Today's topic is intended for final year BDS in for the subject of prosthodontics. Basically, from now on, this is the first week after Eid, so we are starting off after what we called as summer vacations. Now, uh, for quite some time, we will be interacting with the students with through these lectures and some online interactive sessions as well. So, for the whole month of June, I will be covering the topic different topics related to dental implants. Today's topic is just the introduction of dental implants. After that, inshallah, for the next three lectures, um, we'll be covering different topics related to dental implants like osseointegration and prosthesis related to implants. So, starting off with the introduction one, dental implants are basically uh, relatively a modern treatment modality as compared to removable partial dentures and fixed partial dentures. By fixed partial dentures, I mean crowns and bridges, and by removable partial dentures, I mean um, small, you can say, partial dentures and complete dentures. Basically, both the fixed partial dentures and removable partial dentures have a long history of treatment time. They have been with the dentist for quite some time, and many, you can say, most of us are familiar with these treatment modalities, and there are very, you can say, a long history and uh, uh, for of these treatments. And so, if these treatments were very efficient, there would never be a need for a new or modern treatment modalities. But with the conventional treatment modalities of teeth replacement, that is fixed partial dentures and removable partial dentures, we have we have encountered some problem. The dentists over the period of centuries have reported problems with these treatments. So, talking about these problems, why not fix partial dentures in every case? You know, if crowns and bridges are so popular and so long term and so with the patients and doctors as well, why not in every case we provide a fixed partial denture or a bridge? There are some problems with these treatment modalities. Their average lifespan is 50% after 10 years, so that after 10 years of treatment, more than almost half of the bridges or the crowns will be lost. It is a non-conservative option as well. You know that for a bridge to construct, we need two abutments, uh, at least two abutments that we call. I'm talking about very general aspect. There are obviously specificities for every individual case as well. A non-conservative option in a way that if, for example, if there is a first molar missing, we need to have a second premolar present on the anterior side of the edentulous span, and on the posterior side there should be a second molar present, and over these two teeth we will be we will be making a crown preparation, and then there will be a bridge construction over these two abutments. Now, in doing so, two teeth will be, you can say, their natural structure will be reduced or will reduced to some extent, and in order to replace one tooth, we will be compromising two healthy teeth. So that's why they are called non-conservative. Abutment caries is the most common cause of failure. You see that after in trying to save in trying to, giving replacement for one tooth, we are basically putting in danger two healthy teeth. So, and abutment caries, the research shows that abutment caries is the most common cause of failure. RCT is root canal treatment is required for abutments in many cases. Nowadays, what we see in dental practices is that dentists go for elective endodontic treatment for every abutment that they put bridge on, because it's too much complained by the patients that after putting a bridge on you can say a non-endodontic abutment, there is a problem of sensitivity and pain after quite early, uh, quite early after the bridge placement. So so in order to do endodontic treatment after giving the bridge, it's a lot of problem for the dentist. He or she has to remove the bridge first and then do the endodontic treatment, and in doing so, the existing bridge is you can say rendered useless. So that's why dentists do endodontic treatment before providing any elective endodontic treatment, before providing any bridge over that abutment. Periodontal loss of abutment is also a very you can say a very common problem, because the patients, they are not so vigilant in maintaining the oral hygiene, and also around the prosthesis the maintenance of oral hygiene is quite difficult as compared to natural teeth. You have to have flossing, everyday flossing. You have to have interdental brushes present with you, and patients are not so vigilant, and that's why there is a chance of periodontal loss. Aesthetics is also a problem, because porcelain, no matter how you can say modern porcelain is, the problems of shade matching are always there. And porcelain chip off over the fixed partial denture is also a very common problem. You have I'm sure you have come across many cases in during your clinics, that the existing fixed partial dentures have porcelains that are chipped off from the bridges. So moving on, another treatment modality which is provided for missing teeth is removable partial dentures. Now, what are the problems that we encounter during removable partial denture treatment? They are removable. This is a very common problem cited by patients, because it is not psychologically, patients do not cope with the you can say with the fact that they have a removable thing in their mouth while they are speaking, while they are eating, and mostly if patients feel embarrassed in their social gatherings because of these removable prostheses. No matter how retentive they are, they most of the times they do not the well retentive prostheses, they do not come out of the mouth during speaking or eating, but patient somehow is always conscious that he is wearing a removable prosthesis in his or her mouth. Tooth modifications are required, as we have studied in our cast partial dentures, that some tooth modifications are required of the abutments as well. Unaesthetic display of clasps is also a problem, because of in order to provide a sufficient retention, you have to have provision of clasp, which is many patients do not agree with. Need of relining and rebasing, because there is a constant bone loss under the removable prosthesis, and after some time the prosthesis becomes loose, or there is a problem of food lodgement under the dentures. So there is a need for relining and rebasing. So basically there should be a periodic you can say periodic recall of patients in cases of removable partial dentures, and patients do not agree with this. Most of the time patient complain that they have to have it's a very difficult to report to the dentist after every 6 months or 1 year, although it's a good thing, but patients do not agree with this. Bite force is reduced in cases of removable partial dentures. Research shows that as much as 6 times there is reduction of bite force when compared to natural dentition and wearing a removable prosthesis. Masticatory efficiency is also reduced. Patient has to Patient is forced to choose between to choose towards the softer food types, and because of that there are nutritional problems as well for the patients. Continuous bone resorption under the removable prosthesis is also a very common problem, and low survival rate. Uh, uh, the removable prosthesis that we give, the more research shows that almost 60% of that prosthesis will be lost in the first 4 years of the treatment. Repair of abutments is also a problem. Increased mobility, plaque, and periodontal problems of the abutments. These are also a problem for removable prosthesis. Abutment loss within 10 years. Some researches show that because of these, no matter in if the treatment is a bridge or a removable prosthesis, there is a chance of abutment loss in the 10 within the first 10 years of the treatment. So, so these are all the problems that that we face almost in our daily routine at dental clinics. At the other, uh, some dentists think that whether we are providing a service to a patient or a disservice to a patient, if the research shows such a high number of failures and complications, maybe why not leave the space as it is when there is a tooth loss, instead of giving a replacement every time. Is there an option if we just leave the space for the patient and patient has to adjust accordingly, or do we have to provide a prosthesis to patient every time the tooth is lost? So partial edentulism is, which is a common one. You know that the first molars are the most common teeth to be lost in early life of a patient. What are the consequences that we can face? Uh, which which consequences they push us to give some form of prosthesis to the patient? Now, tooth-related problems are the supra-eruption. Here you can see in the on your right side of the panel there are some diagrams in which the opposing teeth have supra-erupted into the edentulous space because of their counterparts are not available in the mouth. Tipping of the abutments, adjacent abutments, are also there. Tilting of the abutments, drifting of the entire dentation, generalized spacing is also another problem, in which the patient often complains to the dentist that that there is some spacing in my दांत, मेरे दांतों में बहुत सारे spaces create होती जा रही हैं और उसमें खाना वगैरह फंसना शुरू हो जाता है, which ultimately leads to periodontal problems as well, because cleaning is not patient is not very vigilant for the cleaning of these spaces, and foods lodgement is can be a very nuisance to the patient. Relative wear of the remaining teeth, because if first molars, if we talk about, for example, first molars, and they are lost in early life, then you can say that the remaining teeth have to have bear a burden of chewing for the rest of the life, and which will lead to fast wear or the early wear of the remaining dentition as well. Sorry. So other soft tissue effects, um, which are you can say related to partial edentulism, are the keratinized gingiva, which is lost and which is replaced by thin loose mucosa, which is readily traumatized. Patient experiences very you can say traumatic ulcers during eating of certain foods when the keratinized gingiva is lost, and over the bone, when the tooth is lost, there is decreased bone height and width. Effects on occlusion are also there. Loss of vertical dimension of occlusion, and patient's lower face height is reduced, and which also affects the aesthetics of the patient as well. Prognathic mandible, this you have I'm sure you have seen in clinics that the old patients with no teeth in their mouth, their mandible is protruded forwards because of the overclosure of the mandible, and that's why this is called a prognathic mandible, and it has an effect on the aesthetics as well as on the health of temporomandibular joint as well. Because of prognathic mandible, the condyle is not in its you can say anterior superior or centric relation position, and there are excessive loads on temporomandibular joint as well. Pseudo class 3 in severe resorption cases, this is the same thing that we have discussed previously. So, moving on to aesthetic effects, some of them have been discussed. Loss of lip support in case of anterior missing teeth. Anterior missing teeth, you know that in today's world and today's age, nobody wants to have you can say less than ideal smile. What we can say is less than ideal smile. If there is a loss of tooth in the anterior portion, there is a severe compromise on aesthetics and also on the lip support. Chin close to nose appearance, which is also what we call in prosthodontics as witch's chin, like in the old stories of witches, in which their chin was very protruded. That is the classic description of an edentulous mouth. Old patient's mouth as well. Reluctance to smile in public, reluctance to speak in public, reluctance to maintain close relationships, psychological depressions and psychological trauma. These are all the additive effects that come with the partial or complete edentulism. So moving on with the now at this point we have you can say we have established that even if there is a single tooth loss, we have to go for some kind of replacement for that tooth. This is excluding the third molars. If the third molars are lost, they are not generally replaced, but all the other teeth, it is you can say a general perception that you have to have some kind of replacement. Now, in the last century, which is 20th century, um, together with a fixed partial denture treatment and a removable partial denture treatment, there is another introduction of replacement option, which is dental implants. Dental implant is a material or device that is placed in oral tissues or bone to support an oral prosthesis. Just looking at an overview, because you know that this is the you can say the introductory lecture. The implant protocol, I will be going through the implant protocol, which is a general map. It does not. It is not necessary that it applies on every case. In a first visit, you record basic information in which patient's history, examination. After everything, you investigate the patient. All the X-rays, baseline X-rays are done. Because an implant is a surgical procedure, so a baseline blood work is also done. After that, implant placement is done. After everything, assuming that everything is going in an ideal pace, then the implant is placed, and after that, sometimes there is immediate placement of crown over the implant, and most of the times the implant is allowed to heal into the bone, which is called giving the time for osseointegration, in which the bone grows around the implant and it stabilizes itself into the bone. After that, there is abutment placement, provision of final teeth after some time, and then there is monitoring cycle, in which there are regular hygiene visits and annual checkups. General indications of implants: single missing tooth. like I said, that first molars are the most prone teeth to be lost early in life, because they erupt when the patient is just 6 years old, 6-year molars. And sometimes because of lack of hygiene, these teeth are early lost early in life. Multiple missing teeth also, we have now implant supported fixed partial dentures as well, in which in place of natural teeth we place two abutments in the one in the anterior portion of the edentulous space, and one in the posterior section, and then we place abutments over these implants, and then a fixed partial denture is constructed, which is derives its support from implants, not natural teeth. Long span fixed partial dentures, Kennedy's class 1 and 2. Now, Kennedy's class 1, you are familiar with these Kennedy classifications, in which Kennedy's class 1 and 2 has no posterior abutments present. So, in those cases, without implant, there would only be one option, which would be removable. No bridge can be provided on natural teeth because there is no posterior abutment present. So, in Kennedy's class 1 and 2, dental implants has basically revolutionized the treatment modalities for these patients. Hyperactive gag reflex, because of these gag reflexes, some patients cannot tolerate removable prosthesis. So, in these cases, dental implants can be a valuable treatment option. Unfavorable number of missing teeth, more than one or two missing teeth, the provision of fixed partial denture can be a very difficult very, you can say, not difficult, but very not a very short span. The long span bridges are their survival rate are very is very less as compared to the short span fixed partial dentures. Poor oral muscular coordination, in which old age patients, we have old age patients, removal prosthesis can be difficult to control by the patient. Poor retention of dentures, there is some there can be a multitude of problems related to poor retention of dentures. Maxillofacial prosthesis, in which there is some kind of defect in the oral cavity, and these defects cannot be covered with the help of bridges and removable prosthesis. If we provide removable prosthesis, their size is too large and their weight is very much increased, which leads to problems. Anchor in orthodontics is also another indication for implants. So, moving on rather quickly, general contraindications are the medically compromised patient, in which there are some kind of surgical compromise, or the surgical contraindication, in which patient we do not go for implant placement. Presence of pathology at implant site, any contraindication to surgery, because this is implant placement is a surgical procedure. Unrealistic expectations by the patient, lack of skills by the dentist during pregnancy and during drug or alcohol users. Moving on. Quickly, I'm giving you a quick overview of different classifications of implants. This Most of them are for historical purposes only. The modern implants have very much evolved. So, based on anatomical side, there is a subperiosteal implant. I'll show you a diagram. Dental implants, which is a metal framework like this. This is a subperiosteal, in which an implant is placed. It is not drilled into the bone, but it is placed beneath the periosteum. Over some places there is provision of screws to retain this metal framework, but most of the implant is resting above the bone and below the periosteum. Chaji, moving second is the transosteal. These implants are usually shaped like a screw or cylinder and are made either of metal covered with ceramic, or ceramic, placed within jawbone, also called blade shaped endosseous. like uh, like these implants in which transosteal. these are these were some of the early treatment modalities, early shapes of the implants. Moving on to end osteal implant, which are the modern implants that we use nowadays in our dental clinics. These are called end osteal, which are placed into the bone. They are in the shape of screw. An implant body that is that it contains pores into which osteoblasts and supporting tissues can migrate and grow bone into these pores, which is also called the process of osseointegration. Osseointegration, which will be the next discussion topic in the next week. So, quickly finishing off today's lecture, I will be another other different types are mandibular staple implants and transmandibular implants. Now, these are just for historical purposes that we see. In some cases, these might be useful in today's age and time, but most of the times we go for endosteal implants nowadays. Consist of a metal plate with a retentive pin that holds it against the inferior border of the mandible. Basically, you see there, when you see these diagrams, you understand that these are these were very you can say invasive type of implants. The shapes are, to be honest, very scary, and basically what revolutionized these all these shapes into what we call are the small screw shaped or tooth-like root shaped implants is was the process of osseointegration. Osseointegration, when it was introduced, then it was able to change the shape of the implants, because before that only dental profession only considered them as mechanical devices which have to be mechanically retained into the bone. There was no concept of fusion of bone into these with the metal as well. So intramucosal inserts and the endodontic implants and the endosteal blade vents, these were all initial shapes of the implants. So finishing off today's lecture, I'm signing off, and inshallah there will be we will try to hold a Zoom interactive session after this video, so that you have this you if you want to discuss any type of ambiguities related to this lecture. Thank you so much.